Okay. Good morning, dear colleagues. Hope you're all well. Today, our project for the cardiology course will be about echocardiography in dogs and cats. My classmates Rita Bitar and Marie-Lynn Issa will be presenting with me. We hope this presentation meets your expectations. Our main goal is to familiarize you with the basics of echocardiography, since we're all aware that echocardiography is a very wide topic and it cannot be discussed intensively with the time provided. Not to forget that echocardiography is a specialty by itself, so we hope to provide you with the essential information. Please do not hesitate to write down any questions you have, and we'll make sure to answer all of them by the end of this session. If needed, you can raise your hand to interrupt the presentation in case a certain idea is not clear. Now, let's begin. For the outline, we will begin with the introduction, then the equipment, patient preparation and positioning, echocardiography modes, echocardiography of congenital heart diseases, and echocardiography of acquired heart diseases. Echocardiography is a non-invasive method of evaluating canine and feline heart diseases. The left and right sides of the chest are imaged with more than 15 different views. Echocardiography is a complementary exam, hence a physical examination. The patient's history, radiography, ECG, and other tests are essential in order to establish a definitive diagnosis. Some indications for echocardiography include coughing, exercise intolerance, arrhythmia, pulmonary edema, pulmonary congestion, collapse or syncope, murmurs, cyanosis, lethargy, weak pulses, and radiographic evidence of heart enlargement. What is echocardiography used for in veterinary medicine? We use echocardiography basically to visualize internal structures, evaluate function, evaluate size, see defects such as valvular lesions, shunts, myocardial abnormalities, masses, effusions, stenotic lesions, evaluate blood flow, and assess myocardial motion and function. Now for the equipment, an ultrasound system having 2D mode, M mode, and Doppler mode is used. It is also important to enter the patient's details and save them for future diagnoses and prognoses in regards to cardiac disease. Ultrasound gel and isopropyl alcohol, these are coupling agents, so they provide better surface contact with the skin, and they prevent the air interface since ultrasound cannot travel through air. Furthermore, sufficient gel application minimizes artifacts, and alcohol allows for better absorption of ultrasound gel. A phased array probe is also used with a frequency of 2 to 12 MHz in small animals. This probe is usually used since it is easy to pass between the rib spaces, and it allows a very high frame rate, allowing a proper visualization of the rapidly moving heart. Higher frequency transducers usually have a better image resolution, but they penetrate tissue less. Lower frequency transducers, on the other hand, have greater tissue penetration. Large dog breeds usually require lower frequency since they require more penetration, whereas cats and small dog breeds require higher frequencies. Also, an echocardiography scan table, such as the one seen here, with special cutouts is used. The probe is placed beneath the animal, beneath the table, since this allows the heart to drop towards the thoracic wall by gravity, and thus creates less lung interference on the images obtained, so no reflection of sound waves from the lungs will occur from this side. Now for the patient preparation and positioning. Patients are usually strained in left or right lateral recumbency depending on the imaging plane desired. In dogs, the right side is shaped from the 4th to 6th intercostal spaces, whereas in cats, the right side is shaped from the 3rd to 5th intercostal spaces. In both dogs and cats, the left side is shaped from the 4th intercostal space reaching the last rib. Regarding sedation, it is not usually required unless the pet is fractious. Most sedatives affect the heart rate, chamber size, and cardiac function, so whenever possible, it is ideal to prevent using sedatives. If needed, dogs can be sedated with buprenorphine and acepromazine, whereas cats are sedated with butorphanol and acepromazine. Ketamine can be added to cats if more sedation is required, but it can undesirably increase heart rate and interfere with thickness measurements. Now for the echocardiography modes. The first mode is the two-dimensional or 2D echocardiography. The second mode is the motion mode or echocardiography. Each will be discussed deeply, thoroughly later on. Then we have the Doppler mode, which is divided into spectral and color flow. The color flow is obvious, and the spectral is divided into pulsed wave and continuous wave modes. So for 2D dimensional echocardiography, it allows for the evaluation of anatomic cardiac changes, whether acquired or congenital. 3 different views are possible in this mode: the right parasternal, which is highlighted, the left parasternal, and the subcostal view. The right parasternal is highlighted since 90% of the routine echocardiogram is done from the right parasternal window according to Huber et al. So only the right parasternal view will be discussed in this presentation. To place the transducer, the apex beat is palpated. Then the transducer is placed on the right parasternal acoustic window, which is located between the 3rd and the 6th rib, intercostal spaces, just below the costochondral junctions. The acoustic windows, what do they mean? They are small regions between intercostal spaces. This is where the transducer will be placed. Because ultrasonography does not penetrate the bony ribs or the air inside the lungs, we have to place it between the ribs. Now for the long axis versus short axis views. To begin with the basics, a long axis view is an imaging plane that is parallel to the long axis of the heart, as seen here in these 2 images. A short axis is an imaging plane that is transverse to the heart, so it is sliced as in images. The heart is seen sliced. When referring to anterior, it corresponds to structures facing the transducer. So taking the mitral valve in the first image, the anterior part would be the one closer to the transducer. The posterior part is the one further away. This is the mitral valve. This is the anterior part since the transducer is over here, and this is the posterior part. Okay. Now for the first view, the 4-chamber right parasternal long axis view. In these images, we can see the right ventricle, the right atrium, interatrial septum, interventricular septum, papillary muscles, mitral valve, left ventricular wall, and left atrium, both in diastole and systole. In this view, the assessment of all 4 chambers, mitral valve morphology, left ventricular geometry and function is possible. The interatrial and interventricular septa should be straight. These should be straight. The left ventricular wall and interventricular septum should be parallel to each other. During systole, the mitral valve leaflets should be thin from tip to base, and they should not prolapse. This is the mitral valve, and its tips should be straight. They should not prolapse. The right ventricular wall has half the thickness of the ventricular wall. You can see. For the second long axis view, the 5-chamber right parasternal long axis view, also known as the left ventricular outflow view. In these images, we can see it is seen that the right atrium, right ventricle, interventricular septum, left ventricular wall, left ventricle, left atrium, mitral valve, aortic valve, and the aorta are all visible. This is a 5-chamber view since it is similar to the previous 4-chamber view, but the aorta is shown here in addition. The morphology of the left ventricular inflow and outflow tract is visualized for allowing for the assessment of the left ventricular function. This is the left ventricle. You can assess the function. This is the inflow, and this is the outflow. During diastole, the mitral valve chamber size, wall thickness, and left atrial size are assessed. During systole, mitral valve should not prolapse back into the left atrium and is thin with uniform thickness as before. The left ventricular wall and interventricular septum should be parallel and similar in thickness as before as well. The aorta and left atrium are similar in size. The right ventricle should be 1/3 to 1/2 the size of the left ventricle. This is the first short axis view image. The right parasternal short axis transverse view of the left ventricle at the level of the papillary muscles. These are the papillary muscles over here. It is also called the mushroom view since the left ventricle obviously has a mushroom shape. This view allows the visualization of the right and left ventricle, the anterior and posterior papillary muscles within the left ventricle, and the pericardium. The left ventricular outer shape should be circular and symmetrical. The left ventricular chamber is mushroom-shaped. The papillary muscles are similar in size. The right ventricle chamber should not be more than 1/3 to 1/2 the size of the left ventricle. This is the right ventricle, and this is the left ventricle. Okay. The second short axis view is the right parasternal short axis view of the mitral valves, also called the fish mouth view. This is the fish mouth view here. No significant data is obtained from this view. It is just a transition to reach the upcoming view. The mitral valve leaflets move away from each other during diastole and move toward each other during systole, creating what is often called the fish mouth view. So the leaflets of the mitral valve cause this appearance when they are active. The third and final short axis view is the right parasternal short axis view at the level of the left atrium and the aorta, also known for the Mercedes-Benz sign. In this view, the structures observed are the aorta and left atrium and are similar in size. We can see the right ventricle, tricuspid valve, right atrium, interatrial septum, left atrium, left atrial appendage over here, pulmonary valve. This is the aortic valve. This is the right, this is the left, and this is the non-coronary side of the valve, aortic valve. Now let's talk about M mode echocardiography. In M mode, a 2D image, such as the one shown in the left, is translated into a 1D image. This is a 1D image, this is a 2D image, over a selected area drawn by one line. This is the line that is drawn over here, it's dotted. So the y-axis corresponds to the depth of the cardiac structures. This is the y-axis. It corresponds to the depth of the cardiac structures, starting with the right ventricular wall, right ventricle, interventricular septum, left ventricular wall. This is the line that is over here. We're just observing it with time. This is its evolution with time, and this is the thickness of the cardiac structures. So we can see how the different cardiac structures at a specific line of interest are changing with time. And notice the ECG in the bottom right of the figure, which serves to compare the cardiac motion during the cardiac cycle. M mode is also used to quantify chamber size and to measure wall thickness. Here are some of the measurements done in M mode. The left ventricular internal dimension during systole and diastole, this one is assessed. The interventricular septum thickness, systole and diastole, left ventricular wall thickness in systole and diastole is also measured. All these measurements will vary depending on the existing pathology and will be discussed later. Now for Doppler mode. This is the last mode we're going to be discussing. Doppler allows the visualization and measurement of blood flow through the heart and vessels. Red blood cells reflect sound while moving. This allows the measurement of the direction, velocity, and character, whether laminar or turbulent, of the blood flow. The ultrasound beam in Doppler must be parallel to the flow or no more than 20 degrees from the direction of flow. Three modes exist, as discussed before: pulsed wave, continuous wave, and color flow Doppler. First of all, the spectral Doppler mode, which consists of pulsed wave and continuous wave. In pulsed wave and continuous wave Doppler, the blood flow velocity with respect to time is studied, preferably with an ECG simultaneously. In this graph, the x-axis represents time in seconds, whereas the y-axis represents velocity in meters per second. A Doppler shift is obtained by red blood cells, as discussed before. The flow towards the transducer is translated above the baseline, whereas the flow away from the transducer is translated below. Now, for a comparison between the modes of action of each of the pulsed and continuous wave Doppler. Pulsed wave Doppler has only one piezoelectric crystal functioning, so it transmits short pulses of ultrasound which are sent and analyzed by the same crystal. Sent and analyzed one crystal only. Because of that, when the blood flow velocity is high, it is difficult for pulsed wave Doppler to analyze and will result in aliasing, a type of distorted wave form. We will see this in the upcoming slide. Continuous wave Doppler, however, uses two piezoelectric crystals, one that constantly transmits ultrasound waves and another that receives signals reflected from each red blood cell. So this allows very high velocities to be accurately measured without aliasing. To obtain a pulsed wave image, a certain sampling area in a specific region is assigned on the machine. This is the sampling area in green, parallel lines on the 2D image on the left. This specific region is then interpreted by waveforms. So this region only is being interpreted over here. These waveforms determine the blood velocity in a precise location with respect to time as well. The second image is an example of aliasing. The waveforms have no peak nor trough. This usually indicates that the blood velocity is high and cannot be read by pulsed wave Doppler. Transitioning to continuous wave Doppler will solve this issue. This is continuous wave Doppler. It allows for the measurement of high velocity blood flow and does not result in aliasing. The last mode of Doppler is the color flow Doppler. It is a type of pulsed wave Doppler, so they share similar characteristics, and thus aliasing is also possible when blood flow velocities are high, and is represented as color reversal. The velocity and direction of blood flow are represented in color on a typical 2D image. There's a 2D image, and there's colors observed on this 2D image. There's no waveform, nothing. The colors are only observed directly on the 2D image. Red corresponds to blood flowing towards the transducer, whereas blue corresponds to blood flowing away from the transducer. Color flow Doppler allows for the movement of blood through the heart to be visualized. A region of interest is selected on a 2D image. This is the region that's selected. The velocity scale shown in this figure, this is the scale. It's black in the middle. And becomes bright red or bright blue as the velocity of blood increases. These images show the aliasing phenomena as seen in color flow Doppler. Notice the yellow color in the left picture, which indicates that there is an increased blood flow velocity. A mosaic of colors, as shown in both pictures, is usually indicative of a certain pathology, such as regurgitation or stenosis. Thank you. These will be discussed in the presentation by my colleagues. Thank you.
Okay, thank you, Elias. Now on to the congenital abnormalities, which will consist in the first two parts of the stenosis of the semilunar valves, and then the atrioventricular congenital abnormalities, then the patent ductus arteriosus, specifically left to right shunting, then the septal defects between the atria and the ventricles, and finally tetralogy of Fallot. Next, please.
Did it switch?
Yes. Okay.
I just want to mute my microphone. Sorry, Marie-Lynn.
Okay, thank you.
I don't bother you.
Okay, we will begin with the aortic stenosis, and as its name suggests, it is a stenosis at the aortic root at the level of the valves. There are several types of aortic stenosis, but of importance is subaortic stenosis, which is the most overrepresented type. So these are a collection of images from the same dog with subaortic stenosis. The left A, B, C, and D are right parasternal short axis images with the M mode, and the right A, B, C, D images include color flow Doppler image. In A, it is obvious that the maximum aortic dimension occurs at the aortic root, at the sinus, at the valves of the aorta. In B, the obstruction, which is labeled as SAS, is obvious, and it is typically right under the valves, and it shows at this short axis view that at the cross-sectional area that this thickness of SAS is quite significant, considering that it takes up a large part of the diameter of the aorta. In C, there is obvious left ventricular wall and interventricular septal hypertrophy, so they are quite thickened, which means that there is concentric hypertrophy. And this is obviously due to the aortic stenosis, since the heart needs to pump more to get out more blood to flow through the aorta. There's also an arrow in C, which is pointing towards hyper-echogenicity, which is thought to represent fibrosis, so it is not yet proven. And this fibrosis is thought to be secondary to ischemia due to the fact that less blood is flowing through the body, thus less blood is irrigating the heart. In D, the M mode through the aortic root shows that the aortic valve leaflet is partially separating in early systole, so it isn't a full separation due to the stenosis right under the valves, the leaflets, so it only quickly returns to its closed position. In the following 4 images, in A, so the subaortic stenosis is quite obvious in this section. And it is also confirmed on the same site in B using color flow Doppler image. It shows that there is a turbulence, a mosaic pattern, so the blood is not flowing properly and smoothly. It is quite turbulent. It is not laminar. In C, which is a long axis parasternal 5-chamber position, is actually during systole. So there's a color halo of a flow convergence zone that is appearing where the flow is accelerating, and there is aliasing proximal to the subaortic stenosis, so at the obstruction. This is where it is going to be found. And in D, so during diastole, it is obvious that there is
بس سريع عم قطشكن بس ماريلين دكتور مش أحسن إذا ماريلين تعمل ريكوست كنترول لتستعمل الكيرسر وتفسر وين؟
Yeah, I can do that.
ايه بترجع يعني بتاخد ايه اوكي اوكي.
Okay, can you see my mouse? My cursor?
Yes.
Okay, thank you, Rita. So in D, this is the same view, but during diastole, as I was saying. Here, the flow convergence zone is also going distal through the aorta. So this is accelerating outside of the left ventricle. So this is also clearly showing or demonstrating that there is some insufficiency, some aortic insufficiency. Excuse me. So this is why the blood is also flowing through the left ventricle. So this insufficiency commonly accompanies the subaortic stenosis, since the blood is not fully going out of the aorta, but going back into the left ventricle. I think I can go to the next slide. Okay. So pulmonic stenosis is quite similar to aortic stenosis, but occurs at the right side of the heart at the pulmonic valves. It is also a common congenital abnormality. These images, the left and the middle ones, are right short axis views, 2D frame and its M-mode image in a dog with pulmonic stenosis and right heart failure, which also commonly accompanies pulmonic stenosis. And the right image is a continuous wave Doppler image in the same dog. So this is an 11-year-old miniature schnauzer that presented with abdominal distension caused by ascites. So it automatically takes us to right heart failure. In D, the pulmonic leaflets, so the small arrow here, are not distinct, and they were actually thickened. There's also severe post-stenotic dilation of the main pulmonic artery and the right pulmonic artery. So this also accompanies the pulmonic stenosis. In this image at the top, the 2D image, where it is obvious that the right ventricle is very distended, so it is quite dilated. And at the M-mode sectioning, so where the points are found, the right ventricular wall is seen to be quite thickened. It is as thick as the interventricular septum and the left ventricular wall, which is quite abnormal. So this shows that there is also right heart hypertrophy in comparison to left heart hypertrophy with the aortic stenosis. In F, the color flow Doppler image, which is aligned here at the pulmonic artery where the dots are found, measured the pulmonic flow, which was negative 4.6, so away of the transducer. So it is actually a 4.6 velocity, which is a very fast velocity to flow through the pulmonic artery back. So this shows that this is a very severe pulmonic stenosis, and not shown here, but the pulmonic regurgitation was 2 meters per second. So not only is it severe pulmonic stenosis, but there's also right-sided heart failure. Okay, on to mitral dysplasia. Mitral dysplasia is an abnormality of the mitral valve in its positioning, in its functioning, in its makeup. And in this case, specifically, there's also accompanying stenosis, which is also common to accompany dysplasia. So these images are taken from a cat that was diagnosed with mitral dysplasia, valvular stenosis, and regurgitation using long axis and short axis images in A and B, with pulsed wave Doppler and color flow Doppler images in diastole and systole in D and E. So in A, it is obvious that the tips of the anterior leaflets of the mitral valve are tethered towards the walls of the interventricular septum and the ventricle. So they are not opening normally, and this is actually due to the increased pressure of the left atrium in this case, due to the mitral dysplasia. And it is obvious as well that the labeled PM, so the papillary muscles, are directly attaching to the leaflets, and this is abnormal. There should be chorditendony between them. So this proves that there is extreme shortening of chorditendony, which is diagnostic of dysplasia. In B, there's also a diminishing of the orifice of the mitral valves, so also showing that there is stenosis. And in C, which is actually a pulse wave Doppler image, it shows that there is a turbulent inflow signal, and the flows are flowing up and down and up and down. This is actually indicative of mitral regurgitation, but it isn't a quite severe one. And in D, so during diastole, there's a flow convergence zone at the atrial side of the mitral valve, and it is flowing back through the left atrium. So there's lots of color aliasing in the left ventricle, so a lot of turbulence. And in E, during diastole, D is the diastolic image. So when it is resting, there's also blood flowing through the both ventricle and atrium. And in E, during systole, the mitral regurgitation jet is flowing back into the left atrium quite severely. Onto tricuspid dysplasia. So it is quite similar to mitral dysplasia, but also occurring at the right side of the heart. So the signs that are expected to be shown are right heart side signs in comparison to left heart side signs in mitral dysplasia. So these are a collection of images of tricuspid dysplasia and accompanying pulmonic stenosis, so two congenital abnormalities in a lab retriever that also had right-sided congestive heart failure. So that is a severe end stage of tricuspid dysplasia with accompanying pulmonic stenosis. Right parasternal long axis short image with color flow Doppler was used in A. The tricuspid regurgitation was quantified in B, and the C and D are the same location, long axis parasternal 4-chamber view, but D also has color flow Doppler image. And so in A, there is actually a marked tricuspid regurgitation into the atrium, as is seen by the color aliasing here. B, this regurgitation was quantified, and if you can see here, it is actually 5 meters per second, which is really crazy high velocity. And this 5 meters per second translates in pressure to 4 times 5 exponent 2, so 100 millimeters Hg, which is a very high pressure, incompatible with a normal right ventricular pressure. So there is abnormal right ventricular pressure, which is, in this case, due to the pulmonic stenosis. It is not seen in these images, but was seen in the previous slides. So this is even worsening the prognosis in this dog. In C, there's extreme dilation of both the right atria and the right atrium and the right ventricle. And similar to what was seen with mitral valve, the tricuspid valve leaflets are tethering towards the right ventricle and the right ventricular wall and the right interventricular septum. So they are long, they are displaced towards the apex, they are abnormal. And D, with color flow Doppler image, the tricuspid regurgitation was demonstrated to be marked, and it is flowing into the right ventricle with lots of aliasing in the right atrium. and also proving that there is a severe tricuspid regurgitation, heart failure. Of course, there are dilated right ventricles and right atria. So all in all, many congenital abnormalities presented. Now on to patent ductus arteriosus. So the DA is a vessel that connects the pulmonic trunk to the aorta at the embryonic phase, and shortly after birth it should shut off. In some rare cases it is still patent, and there are two types. There is the right to left patent ductus arteriosus and the left to right one. The main concern of this presentation will be the L2R, since it is presented in more than 90% of cases of PDA. So these are a collection of images from the same puppy presenting left to right PDA. So A and B and C are 2 DE images, short axis view with accompanying M mode, and the DE and F are right parasternal short axis views with color flow Doppler. So as is suggested in both A and B, the left ventricle is obviously quite dilated. So there's a big stroke volume overload, since there's lots of blood flowing through the left ventricle due to this shunting. And in C, the EPSS, which will be also discussed later on by my colleague Rita, seems to be in this case increased. So EPSS, endpoint septal separation, is the separation between the mitral valve and the interventricular septum, which should be smaller than this usually, but since the heart is dilated, there is more space to cover, so the valve cannot reach the interventricular septum. So this is also indicative of left ventricular dilation, which is also suggestive of marked ventricular remodeling and deterioration of the myocardial function. D and F enable us to visualize the actual ductus arteriosus, and with the use of the color flow Doppler, the clinician can be 100% sure of its location. So in D, where there is a labeling of DA, the ductus arteriosus is obviously tapering and narrowing into the pulmonic trunk. So there is a color flow Doppler in E at an abnormal location where blood should not actually flow. And not important, not significant at all. This is a mirror image artifact. It's just an artifact. And E and F are both systole and diastole, respectively, phases of this heart showing the turbulence flowing into the pulmonic trunk and back from it. Now on to the septal defects. So a septal defect is a hole inside a normally intact septum that separates either the atria or the ventricles. In interatrial septal defect, as the name suggests, there is a connection between the atria. So these are 2 images of right parasternal long axis view with color flow Doppler, but it is not obvious in a black and white image. Of the same puppy. It was presented for vaccination, and there was a loud murmur that was auscultated. After using echocardiography, it was obvious that there is an interatrial septal defect between the right atrium and the left atrium. So this is where the arrow points. And color flow Doppler image was used to assess or to qualify this flow from the left atrium into the right atrium. Similarly, interventricular septal defect is also diagnosed using echocardiography. These are 3 puppies, D, E, and F and G together, that were all presented for vaccination, where a murmur was auscultated and a pronounced precordial throb was palpated. In the German Shepherd in D, there is obviously at the arrow a hypoechogenicity, so there is like a connection between the left and right ventricles, which is indicative of interventricular septal defect, and it is seen high in the interventricular septum. So there are 2 types of interventricular septal defects: high interventricular septal defect under the atrial septum, and there's a lower one that goes towards the apex, towards the base. In E, the Staffordshire Bull Terrier was also shown to have an interventricular septal defect, and in this case, the septal wall between the hole is also hypertrophied and a bit stenotic. F and G from the same puppy show actually a thinning of the interventricular septum right under the interatrial septum, and this is where the flow of blood is passing through from the left ventricle to the right ventricle. And G is also another visualization from the same puppy, and this is actually a section of the aortic outflow tract, so the aorta showing from the left ventricle here. And this is not obvious, so the septal defect is not obvious in this sectioning, but it could also be quantified in G and using color flow Doppler image observed more easily than in F. And finally, probably the most interesting congenital abnormality that could be discussed is Tetralogy of Fallot. So it's an array of other congenital abnormalities. Its pathognomic four components are pulmonic stenosis, interventricular septal defect, an overriding or dislocated aorta, and a right ventricular hypertrophy, so right heart hypertrophy. This is an image from an 8-month-old mixed breed puppy using the right parasternal lung axis view. The small arrows are pointing towards the interventricular septal defect that was seen in previous images. So there is a connection between the left and right ventricle. The aorta is seen to flow out of this interventricular septal defect. So it isn't coming right out of the left ventricle, which is abnormal since the aorta only flows out of the left ventricle. So this is indicative of an overriding aorta, a displaced overriding aorta. The long arrow is pointing at the right ventricular wall, and comparing it to the left ventricular wall, it is obviously very, very enlarged, very thickened. So this is also a third component of Tetralogy of Fallot, right ventricular hypertrophy, and not seen in this image, but observed in the first slide of the congenital abnormalities. There is also pulmonic stenosis. So this was the fourth component of Tetralogy of Fallot, and these four findings are usually always consistent of this disease. Thank you. Now on to Rita Bitar.
Okay. So several diseases in this part will be covered, mainly the acquired cardiac diseases. The first of them is degenerative valvular disease, then going into infective endocarditis, then both dilated and hypertrophic cardiomyopathies, and eventually briefly about cardiac neoplasia and its relation to pericardial effusion. First of all, degenerative valvular disease. This disease is very common in the dog, and it mainly affects the valves of the heart, and most commonly it affects the mitral valve. So that's why it is commonly called mitral valve disease. This disease is characterized by the thickening of the leaflets and the presence of nodules or hyperechogenic nodules at the base of these leaflets, leading to their inadequate closure and subsequently leading to regurgitation or backflow of blood from the ventricles towards the atrium. In these 2D images, these are two different cases of MVD. In A, we have a marked dilation of the left atrium. This dilation is mainly caused by the volume overload caused by the regurgitation of the blood from the ventricles into the atrium. There is dilation of the left atrium, and there is a 2-to-1 ratio, which means that the left atrium is 2 times bigger than the aorta. Most of the time, this is an indication of heart failure. While in B, we can see that there is a prolapse of the mitral valve from the left ventricle into the atrium. This prolapse indicates the presence of rupture, indicates the rupture of the chordae tendon. غير شي السلايد ما بغير. Okay.
Yes.
Now going into M mode. In A, there is an important concept in this case that needs to be covered. This concept is the fractional shortening. Fractional shortening measures the contractility of the heart or the function of the myocardium. So in cases of disease or in degenerative valvular disease, the heart has to pump more blood in order to increase the cardiac output. So it has to show more myocardial function and more contractility. So in A, these are two separate cases of mitral heart disease. In A, on M mode, there is marked increased fractional shortening, which means that there is increased contractility of the heart. So the heart is able to compensate the cardiac output. But in B, this compensation isn't present. There is a decrease of fractional shortening. And this indicates that this is a decompensated state of the disease or an end-stage disease. Now, onto Doppler mode. This is a color Doppler mode. This mosaic color shows a turbulent flow of blood going through both sides, from the left ventricle to the atrium and from the atrium to the left ventricle. And the arrow here is showing a very narrow closure, a very narrow opening during systole, which means that the mitral valve is not closing properly. Okay. Now going into infective endocarditis. Infective endocarditis is a disease caused by septicemia or bacteremia, and the vegetation of the vegetations or the bacteria reach the heart and they infect the lining, the interior lining of the heart. Mainly and mostly they infect the mitral, the valves. Most of the time the aortic valve is affected and the mitral valve, but the aortic valve is more commonly affected. When we see that the mitral valve is affected in this case, or only the mitral valve, this can be mistaken for MVD. Because of the similar characteristics such as the presence of nodules and the thickening of the leaflet. In these cases, we have an infection of the aortic valve. In A, B, and C, we can see the vegetation that is causing an obstruction inside the aorta or in the left ventricular outflow tract. And in Doppler mode, we can see that there is a high turbulent blood flow, and this turbulent blood flow is going from the left ventricle, when the blood is going from the left ventricle towards the aorta, meaning that we have an obstruction at this level, as seen in B. There is the vegetation that is causing this obstruction and is causing this dysfunction of the leaflet. Okay, this is interesting here on M mode because in A, these two M modes are from the same case. In A, it is the case of it is at the level of the mitral valve, and in B, it is at the level of the aortic valve. A shows a diastolic flutter of the mitral valve, and it shows that there is a premature closure of the mitral valve, indirectly indicating a deformity or a problem with the aortic valve, because when there is a premature closure of the mitral valve, it means that there is a pressure during systole, an increased pressure during systole on the ventricles, meaning that there is regurgitation of blood from the aorta to the ventricles, causing this premature closure. In B shows the weak chaotic movements of the leaflet, of the aortic leaflet, indicating that the vegetation and the bacteria has destroyed and demolished the aortic valve. Now, before going into dilated and hypertrophic cardiomyopathies, this image is important because it will explain the anatomic localization of the left ventricular outflow tract, which is between the anterior leaflet of the mitral valve and the interventricular septum. Also, there is an important notion, which is the EPSS, which was discussed earlier by Marie-Lynn. The EPSS, or the endpoint septal separation, is the endpoint of the leaflet, is the endpoint of the anterior leaflet of the mitral valve and the interventricular septum. It's this space right here, okay? In dilated cardiomyopathy, as it is known, dilated cardiomyopathy is a disease that affects the heart chambers, where we have dilation of the chambers. Mainly the left side is more affected than the right side, but most of the time all of the heart is affected. In the 2D images of C, B, and D, there is marked dilation of these chambers, and in D we can see the 2-to-1 ratio discussed earlier, left atrium 2 times bigger than the aorta. This indicates heart failure. On M mode, we can see that the space between the left ventricular wall and the interventricular septum is increased, so indicating that there is a dilation. And interestingly here, the endpoint septal separation is also increased because the endpoint of the mitral valve is further away from the interventricular septum, leading for this increase of this space. Okay. Okay. On Doppler, in this disease, there is also mild regurgitation of blood caused by the inadequate closure of the valves that is also caused by this dilation of the heart. But this regurgitation is seen on both sides, as seen in A. In the right, there is this turbulent flow from the right ventricle to the right atrium, and also in B, this turbulent flow is present from the left ventricle to the left atrium. So there is regurgitation of blood, and the blood is going in 2 ways at the same time, causing this turbulent blood flow. Hypertrophic cardiomyopathy. This disease is very common in the cats. It is mainly characterized by the thickening of the walls of the ventricle, of the left ventricle most of the time. This thickening also leads to the narrowing of the lumen of the ventricles. And since the lumen of the ventricle is narrowed, it cannot hold enough blood. So the remaining blood will remain in the left atrium, causing the left atrium to become dilated. So on 2D images, we will see the very thickened walls right here, and a very small lumen. And at the level of the left atrium, we will see the 2-to-1 ratio that is discussed earlier, which indicates the heart failure. So the left atrium is 2 times bigger than the aorta. This is caused by the volume overload. Okay, this is very interesting. These are 2 cases of hypertrophic cardiomyopathies. In A, these M modes were taken at the level of the mitral valve, or the endpoint septal separation that was discussed earlier. Where there is the arrow here. In the first case, there is a small distance between the mitral valve and the interventricular septum, meaning that this is a normal case. A normal case that isn't presented with LVOT obstruction or left ventricular outflow tract obstruction. But in B, these spaces are narrowed, as seen in these at the level of these arrows. So this means that the anterior leaflet of the mitral valve is actually prolapsing into the left ventricular outflow tract, leading to this obstruction. And this is even more confirmed on Doppler, where there is a very turbulent blood flow at the level of the left ventricular outflow tract, or when the blood is going from the left ventricle to the aorta. So the leaflet of the mitral valve is prolapsing into the left ventricular outflow tract, which is a common finding in hypertrophic cardiomyopathy, leading to this obstruction. In this, sorry. It's also seen, I can explain it on this image even more because it's more obvious. This is the anterior leaflet, and in the case that was discussed, we can see that this leaflet is prolapsing into the left ventricular outflow tract, causing this obstruction. Okay. In the last Doppler image, this is a spectral Doppler image. They have used the continuous flow because of the high velocity, the continuous wave because of the high velocity of the blood in this region here. So this high velocity of the blood indicates the obstruction that was discussed earlier. Now, lastly, cardiac neoplasia and pericardial effusion. The two most common cardiac neoplasia are hemangiosarcoma and heart-based tumor. Hemangiosarcoma usually originates from the right atrium, and it can go into the pericardial space, and it can also protrude into the atrial chamber and in the atrioventricular groove. And usually it's consistent with the movement of the atrium, while heart-based tumor is found at the base of the ascending aorta, and it can become diffused and surround the aorta and the main pulmonary artery. This is a 2D image of a hemangiosarcoma that is attached. As we see here, it's attached to the right atrium. The appearance of this tumor is usually cyst-like, which means that there is a hypoechogenic interior with a hyperechogenic lining surrounding it, causing it to look like a cyst. It's attached to the right atrium, and it's almost always associated with pericardial effusion or the presence of fluids in the pericardial spaces, showing this anechogenic appearance right here. And it's also consistent with the movement of the right atrium, or consistent with the as seen in B and C. In B, this is during systole, and in C, it's during diastole. So it's moving with the movement of the atrium or with the cardiac cycle. Also, one of the features that are seen on ultrasonography in this case is when the atrium is contracting, the mass is causing this protrusion, leading to the presence of this indentation right here. So most commonly during systole, this indentation will be present, and this will show the mass even more. And as discussed earlier, there is always a pericardial effusion present surrounding the heart. Okay, lastly, heart-based tumor. The difference between heart-based tumor and hemangiosarcoma is that it is usually attached to the aorta and not the atrium. It's also a homogeneous mass, not a cyst-like mass. So as seen in these images here, the homogeneous mass is attached to the aorta, and sometimes this can cause an obstruction of the left ventricular outflow tract or a narrowing of the aorta. And also right here, it's very obvious, the mass in B, and we can see that there is also pericardial effusion. So cardiac neoplasia is almost always accompanied by pericardial effusion. Thank you so much.